Good evening, all. Today we have Dr. Rehna, faculty in Department of Ophthalmology, and the session is titled Diabetic Retinopathy. Dr. Rehna, can we start?
Yes, I'll start.
Okay. Thank you.
Okay. Good evening, all. Its topic is diabetic retinopathy. So I'll be going through an overview of diagnosis, evaluation, classification, and management of diabetic retinopathy. So diabetic retinopathy, as you know, is a chronic, progressive, potentially sight-threatening disease of the microvasculature of the retina, which is associated with prolonged hyperglycemia and the conditions linked to diabetes mellitus, such as hypertension. So regarding the epidemiology, the estimates show that more than 360 million people will be affected by DM by 2013, and 79.4 million Indians will have DM by 2030, the largest number in any nation in the world. Prevalence of DR in India in various studies ranges from 20 to 30. It's becoming an increasingly significant public health problem. So pathogenesis, mainly it is a hyperglycemia which is causing the problems in the diabetic retinopathy. And if you look at the capillaries, it's a capillaries which is majorly affected, where there is loss of pericytes, which causes this saccular outpouchings of the capillaries, which is called microaneurysms. So along with that, there is thickening of the basement membrane of the capillaries, and the rolae formation and stickiness of the platelets. All these can lead to minor occlusions in the capillaries and can cause ischemia. So along with this capillary damage, because of the capillary damage, the vessels can leak, which when it leaks into the retina, it is called retinal edema. And if this leakage is into the macula of the eye, it is called macular edema. And also, when there is chronic ischemia, the shunts between the arteries and the venules, called the AV shunts, they dilate and they can be seen clinically, and they are called IRMAs, or intraretinal microvascular anomalies. So these will be seen in areas which is near the capillary non-perfusion. And when there is a lot of ischemia of the retina itself will produce certain substances like vasoformative substances like VEGF, vascular endothelial growth factor, which would stimulate the production of new vessels on the retina. So these vessels can bleed and can result in hemorrhage into the vitreous, which can cause loss of vision. So looking at the risk factors, we all know longer the duration of the diabetes mellitus, longer all the systemic associations or systemic problems like nephropathy or neuropathy. Similarly, diabetic retinopathy also affect the eye if the duration of the diabetes is more. And also control of DM. If there is tight control of blood sugars, less chance of diabetic retinopathy. If the control of the diabetes mellitus is not that much, there could be more incidence or prevalence of diabetes and also worsening of diabetic retinopathy. So the large studies like DCCT, or Diabetes Control and Complication Trial Research Group, and UK Prospective Diabetes Study Group have shown that with tight control, DR is less. Similarly, with nephropathy, patients who are already having a nephropathy, diabetic nephropathy, high chance that the diabetic retinopathy is also there. And hypertension accelerates the process. Similarly, increased serum lipids, then carotid non-perfusion, high BMI. These are all risk factors for diabetes retinopathy. Similarly, pregnancy. In pregnancy, the staging of the diabetic retinopathy can get worse. So these patients require more regular follow-up. So now let's go to how do you classify the diabetic retinopathy. It is important that there is specific classification, and we should all, physicians, endocrinologists, ophthalmologists, should be speaking the same language for the better treatment of the patient. So broadly, they can be divided into non-proliferative, proliferative, and proliferative. And maculopathy means that the macula is affected. So first of all, let me show you how the fundus look like. This is a fundus of the left eye of a normal patient. And this is the disc, which is actually the anterior part of the optic nerve, which is formed. Optic nerve is formed by all the fibers from the retina merging here to form the optic nerve. And the anterior part is optic disc. Then you can see the vessels going. The thinner one is artery, the thicker one is a vein. And this area is the macula. So macula is seen when you're looking with the direct ophthalmoscope, seen temporal to the disc. So it is bordered superiorly by the superior arcade and inferiorly by the inferior arcade, and nasally there is a disc. So macula is the area where you get the maximum vision. So what are the features of non-proliferative diabetic retinopathy? So the microaneurysm is the first sign that occur with a diabetic retinopathy. So it looks like a single tiny dot in the fundus. So like that, it will be seen, and it is due to the sacral outpouchings of the capillaries, and the microaneurysms can leak and can cause retinal edema. And then the other feature is dot and blot hemorrhages like this, the big blot hemorrhages or dot hemorrhages. Dot hemorrhages, it looks similar to microaneurysm, but by doing fundus fluorescein angiography, about which I'll come to later, we can differentiate. And these occur either due to a rupture of microaneurysms or due to like cluster of the capillaries, which is blocked and causing deep retinal infarcts. So this is another picture where you can see blot hemorrhages here, then tiny dot hemorrhages. And this is a fundus fluorescein angiography where these blot hemorrhages will be seen black. Other feature of non-proliferative diabetic retinopathy is hard exudates and retinal edema. So when there is damage to the capillaries of the retina, there will be chronic leakage, that is fluid coming into the retina. So when you look at the direct ophthalmoscope, you see like a boggy swelling of the retina or the macula. And but it is very difficult to see the 3D effect on direct ophthalmoscope, for which we need a slit lamp biomicroscope or an indirect ophthalmoscope. But this yellow hard exudate can be clearly seen. So these are occurring because when there is leakage from the capillaries and retinal edema, this allows leakage of serum proteins and lipids from the vessels, which will be seen as hard exudates. And these are seen actually in the deeper layers of the retina, in the outer plexiform layer. Then cotton wool spot. Cotton wool spot is seen in a lot of conditions other than diabetic retinopathy, and it is sometimes confused with the hard exudates. Cotton wool spots are white in color and it's fluffier like that. But hard exudate is yellow in color and its margins are a bit more well defined. And cotton wool spot seems superficial, because when you're looking at the fundus, what you see is a nerve fiber layer, which is superficial, and deeper layers like outer plexiform, there hard exudates occur, but in cotton wool spot occurs at the nerve fiber layer. It occurs due to occlusion of the precapillary arterioles. Other changes are, this is venous looping. Then here you can see beading here, venous beading. And apart from that, other non-proliferatory changes also you can see, like blot hemorrhages, cotton wool spots and all. Then another feature is IRMA, or intraretinal microvascular anomalies. So this is a bigger one, intraretinal microvascular anomaly. So this occurs at the border of a capillary non-perfusion area. It's adjacent to this ischemic area. So it is a feature of a severe non-proliferative diabetic retinopathy. So most of the times what we get confused is whether it is a IRMA or a new vessel. So one of the tests by which you can differentiate is by FFA, or fundus fluorescein angiography, where IRMA will not leak on fundus fluorescein angiography, but new vessels will leak on fundus fluorescein angiography. So that was a non-proliferative diabetic retinopathy, where we went through the features of non-proliferative, which include microaneurysms, dot and blot hemorrhages, cotton wool spot, retinal edema, hard exudates, IRMAs, venous changes. So when it comes to proliferative, which means that there are proliferative changes of DR, which is a new blood vessels. The new blood vessels occurs when there is a lot of ischemia of the retina, which induce the formation of VEGF. So here, you can see here on the disc, new vessels are there. So when the vessels are there on the disc, we call it NVD. So either on the disc or one disc diameter from the disc. But it's away from the one disc diameter, it is called NVE. So NVE and NVD are features of proliferative. Similarly, vitreous hemorrhage and pre-retinal hemorrhage are also features of proliferative. Vitreous hemorrhage means when these new vessels bleed into the vitreous, it is vitreous hemorrhage. Pre-retinal, it's between the retina and the vitreous. So this is a pre-retinal hemorrhage. This is a vitreous hemorrhage where you cannot clearly see the details of the retina. Here it can see it's a bit more red, but it's between the vitreous and the retina. And here it's an advanced stage of diabetic retinopathy where there is a lot of fibrovascular proliferation on the surface of the disc. And this fibrovascular proliferation can actually pull on the retina and it can cause detachment of the retina. It's called fractional retinal detachment. So this is a complete retinal detachment of the eye. So till now, we were going through what are the features of non-proliferative and proliferative diabetic retinopathy. So classification, it can be, there are a lot of classifications. The most common are ETDRS, or early treatment diabetic retinopathy study, which is mainly used for research purposes. it's a detailed one. The commonly used for the clinics is International Clinic Disease Severity Scoring, which is a simplified version. The other two classifications are National Screening Committee, which is used for screen the patients from photographs and all, which is used in United Kingdom, and American Academy of Ophthalmology International Classification. So this is ETDRS grading, which is actually having a scoring system. So it is based on 7 stereoscopic fundus images. So we can see here 1, 2, 3, 4, 5, 6, 7. So including the disc and macula here, then supratemporal, infratemporal, infranasal, supranasal. So likewise, you get 7 images, and based on that, there is a scoring system for the diabetic retinopathy, which is usually used for research purposes. But it was from the ETDRS, this 4:2 rule of severe NPDR was found, because if there is severe NPDR, 50% of them will develop into PDR in 1 year. So these patients should be carefully followed up. So it says that 4 means if there are hemorrhages in 4 quadrants, more than what you can see here, or if you have venous bleeding in 2 quadrants like that, or if you have irmas like that in 1 quadrant, then you can call it as severe NPDR. Okay, so yes. So there is also a clinically significant macular edema, which is actually the diabetic retinopathy. In diabetic retinopathy, the macula is involved with edema. So this word was also coined with ETDRS, which is actually the diabetic macular edema that threatens the center of the macula, which is called the fovea, and it is a basis of current treatment. So it's diagnosed if there is, so if this is a disc, this is the macula. So this is the fovea, that is the center of the macula. So if there is a thickening, retinal thickening, which is involving this 500 micrometer of the center of the fovea, it is called clinically significant macular edema. So, or if there is hard exudates here, again in the same location, then along with the retinal thickening, it is called CSME. So here it's just retinal thickening. Here there is hard exudate, but the edema need not be there at the center. It can be away from there. And also, if there is a large macular edema involving more than 1 disc area, any part of it is within this 1 disc diameter, then it's again CSME. So it is based on this that laser treatment for the clinically significant macular edema was set by ETDRS. So this international clinical disease severity score is easier, where it's just, when if you look at the DR, it's no DR, mild, moderate, severe, proliferative. It's an easier classification. So no DR means there is no changes of diabetic retinopathy. Mild means if at least there is 1 microaneurysm, it will go into mild. But there should only be microaneurysm. If there is anything more than microaneurysm, it will go into moderate. Severe, as I said, the 4:3:1, where any of the following 20 or more intraretinal hemorrhages in 4 quadrants, or there is a definite venous bleeding in 2 or more quadrants, or if there is a prominent, not a small, prominent irma in 1 or more quadrants, then it is severe NPDR. So anything less than severe but more than mild will come into moderate. So any proliferative features are there, then it is proliferative diabetic retinopathy, which is an easier classification. So this is mild, just microaneurysm. So this is moderate, and this is severe. So again, for this, there is a DMO classification or diabetic macular edema classification, which just says if there is diabetic macular edema, it is present or if it is absent. So here there is no diabetic macular edema. So there is no diabetic macular edema present, it is present here. So that is whether present or absent. And when it is present, you can again divide into mild, moderate, severe. There is some thickening which is well away from the fovea, it is mild. If it is just abetting the fovea, it's moderate. It's completely involving the fovea, it is severe. So that is the international classification. Now we will go to what are the imaging that we have, or what are the investigations. So you might have come across this pictures with the diabetic retinopathy patients. It is an optical coherence tomogram image, OCT. So it is a investigation by which you can see different layers of the retina. This is a normal picture. So in diabetic retinopathy and diabetic macular edema, we can know whether the retina or the macula is swollen, if there is edema, and if whether the patient is responding to our treatment, and the different layers, is there any problem with any of the layers, whether the photoreceptor layer is already gone. We can prognosticate the patient. All these things we can do with OCT. Actually, OCT is one of the indispensable investigation in diabetic retinopathy nowadays. So here you can see that compared to the normal one, it has swollen up. The macula is edematous now. So there is diabetic macular edema on OCT. So not only that we diagnose there is diabetic macular edema, we can also know what is a different type of diabetic macular edema. This is a kind of diffuse diabetic macular edema. There you can see cystoid spaces. It's called cystoid macular edema. And here it is called sensory neurodetachment. That is when there is a fluid between this retinal pigment epithelium and the sensory retina. So the retina has 10 layers. The outermost layer is called the retinal pigment epithelium. The rest of the layers we call it sensory retina. So when there is a fluid between these two, it is called sensory neurodetachment. Or you can see if there is any abnormalities on the vitreoretinal surface. So this is the retina and this is the vitreous. This area is the vitreous, this is the retina. So on the surface, you can see a hyperreflective layer. It's actually thickened surface, or you can call it as a epiretinal membrane, or if there is any traction on the macula, all these things you can find on OCT. So that is very important in DR. The other investigation which is commonly used is fundus fluorescein angiography. Fundus fluorescein angiography is an investigation where dye called fluorescein is injected into one of the veins, and when the fluorescein reaches the retinal circulation, photographs are taken, so we can study how the dye behaves in the eye, whether is there any delay in the dye reaching the eye, or if there is how much ischemia is there in the retina, how many areas is not getting perfused, and if there is any new vessels there, or if there is any ischemia of the macula. All these we can find from FFA. So that is some of the normal pictures where here the dye is just going through the artery now. Now it has reached the veins, and now it has reached the veins, artery, and the whole of the retina. Like that, you can learn from the FFA. So let's go through two cases. The first one is a 46-year-old male who presented with decreased vision in both eyes for 1 year. He was diabetic since 15 years and is on oral hypoglycemic agents with systemic hypertension for 1 year. And he is also recently diagnosed with chronic kidney disease, and he is referred to the ophthalmology for diabetic retinopathy evaluation. So he is moderately built and nourished with pallor and pedal edema. Blood pressure was 180/100 and heart rate 112. So if you look at the visual acuity, it is 4/60, that he can see up to 4 meters with pinhole improving to 618, which means that he has got a refractive error, and with pinhole it is improving to 618. Similarly, left eye 4/60, it is improving to 624. That is, normal vision is 6/6, so it's not reaching up to 6/6. There is some pathology in the retina which is actually causing problem with the vision. So this is some anterior segment examination which was found to be normal, except for a pallor in the conjunctiva. And intraocular pressures is 16, and in the right eye and left eye 19. So this is a fundus picture. So this is a disc where you can see tiny blood vessels on the surface, which is actually new vessels on the disc. And these are the veins, these are the arteries, and here you can see a small superficial hemorrhage. Here there are, you can see an occluded vessel, yellow looking, and there are a lot of exudates at the macula. But then I cannot see any edema there, so it's only exudates there. So I would call it proliferative diabetic retinopathy in the right eye with the maculopathy, no CSME. In the left eye, on the other hand, again, there are tiny new vessels here on the disc. So this one is cotton wool spot. So these are superficial hemorrhages. Here you can see that there is an occluded vessel here, plot hemorrhages. Then here you can see a lot of hard exudates and thickening. So it is a case of proliferative diabetic retinopathy with diabetic macular edema or CSME. So this patient is having both a high proliferative diabetic retinopathy with a cystoid, clinically significant macular edema, grade 3 hypertensive retinopathy, that is our changes of hypertensive retinopathy as well. Type 2 diabetes mellitus, systemic hypertension, acute and chronic kidney disease. So this was the OCT finding of this patient in the right eye. OD is right eye. So this doesn't appear that swollen. Some swelling is here. In the left eye, you can clearly see the swelling at the macula. So there is diabetic macular edema in both the eye, but it's the left eye is more. So now we are going through the fluorescein angiography. So I'll show you a better picture. Yeah. So here this the vessels are all filled up now. And here you can see some abnormal vessels here. So these are all appearing uniformly white, but this area, there is no perfusion. This area is capillary non-perfusion areas. And if you go further, you can see that these vessels have started to leak. So by leaking, we mean it's getting more and more white or hyperfluorescence. So this area is actually a new vessel. So clinically, we could see the new vessel on the disc, but this was not that clinically apparent, which is evident on fundus fluorescein angiography. We can also see the CNP areas here. And these are all completely ischemic. So this is venous beading. These are all venous beading. Here again, abnormal vessels are there that looks like irmas. So that's one of the, those are the findings in FFA, which would help us to, if there are no clinically visible new vessels, FFA would help us to diagnose a PDR. Now, the second case, again, 55-year-old lady with poor control of DM, with visual acuity of 612 in the right eye and 618 in the left eye. With, you can see that it looks more like a severe non-proliferative diabetic retinopathy with macular edema, but I couldn't see any new vessels. Ideally, we should be seeing all the quadrants as well to clinically diagnose whether it is in PDR or PDR. So we did an FFA. In the FFA, you can see here there is a hyperfluorescent area which is due to new vessels. So again, if we were not able to diagnose a proliferative stage from clinically, but from the fundus fluorescein angiography, we will be able to diagnose proliferative diabetic retinopathy. Okay. So, and another investigation that we nowadays use is called OCT angiography. Again, it would help us to know the vasculature of the retina without an dye. So here, this is an area of capillary non-perfusion. So it's being used nowadays more and more in a lot of retinal conditions. It's called OCT angiography. So how do you treat a case of diabetic retinopathy? So definitely that requires systemic control of diabetes mellitus and all the risk factors. And if there is no diabetic retinopathy, or if it is just a mild non-proliferative diabetic retinopathy without any macular edema, the patient can be observed and reviewed after every year. So mild NPDR and no DR, the patient should be reviewed every year. But if it is moderate NPDR without macular edema, review after 6 months. If it is severe or PDR, then you can advise laser. For proliferative diabetic retinopathy, we advise laser. Severe NPDR also, laser can be done if you think that the patient is not coming, it's not possibly not going to come for follow-up. Then there is a surgery called vitrectomy where we go into the eye, the vitreous is removed, the lasers are all done. It's called vitrectomy. That is done for advanced diabetic retinopathy when there is a lot of vitreous hemorrhage which is not resolving, or if there is fractional retinal detachment. Then if there is macular edema which needs to be treated, different ways of treating it is you can give laser to macula, or you can give anti-VEGF injections or steroids. The different anti-VEGF injections are there available, and you choose according to each patient. Then vitrectomy is with the membrane peeling can be done as required. So this is a photograph of a lasered eye, right? So why do you laser the eye? Because the eye is quite ischemic, retina. So we are actually converting the ischemic retina into completely anoxic area, so that that VEGF drive is reduced. That is a stimulus for neovascularization is reduced. So we are actually destroying the extramacular ischemic retina. And the studies like diabetic retinopathy studies has shown that it would reduce the risk of severe vision loss by 50%. So it says that when retinopathy is severe, laser scatter photocoagulation should be considered, and usually should not be delayed if the eye has reached the high risk proliferative stage. So according to the ETDRS and DRS study, we are doing pan-retinal photocoagulation for patients with proliferative diabetic retinopathy. Pan-retina means the whole periphery of the retina is lasered. Then there is another study called DRCR Protocol S, which actually tried to give anti-VEGF injections in proliferative diabetic retinopathy patients without macular edema. And they found that, yes, it is useful, but this anti-VEGF injections have to be repeated regularly, which is not possible in the Indian scenario. So that is not practiced. And these are a lot of other treatments which are available for the macular edema in the eye. You can either go for laser photocoagulation or ranibizumab injections or bevacizumab injections, aflibercept or implants, which is steroid implants. These are some of the treatments which are available, and depends upon each and every patient. So according to the OCT, you can divide the macular edema into either it is involving the center, it is involving the center, it's not involving the center. So if it is not involving the center, away from the center, you can actually go for laser photocoagulation. But if it is involving the center, then these are the treatment options which are available. So how do you laser? It depends. As I said, it will be given like that away from the center. So either apply directly to the microaneurysm, or it can be given to the area of retinal thickening. Okay. And there are a lot of trials of these anti-VEGF injections in macular edema. Some of them, one is the RISE and RIDE trials, which actually tried ranibizumab injection compared to the sham. Okay, and they found that the visual acuity is much better in the patients who receive ranibizumab compared to no treatment. And also there is another trial called Protocol T, which compared the 3 anti-VEGF injections, that is bevacizumab, the ranibizumab, and aflibercept, and they found that 3 of them are equally good. So there are multiple treatment options for diabetic macular edema. The choice depends on several factors. Whether there is the vision is affected. Sometimes there will be mild diabetic macular edema, the vision is not affected, then we can observe the patient. Whether the macular edema is involving the center or not, then if the patient is vitrectomized, pseudophakic, the patient's choice, the expense, then the medical condition of the patients, because in certain conditions like recent MI or a recent stroke, we wouldn't go for anti-VEGF injections, we'll go for the steroid implants. So when do you go for vitrectomy in diabetic retinopathy? There is a persisting vitreous hemorrhage which is not resolving, or tractional retinal detachment which is involving the macula, a combined retinal detachment, a premacular fibrosis, pre-retinal hemorrhage involving the macula, and there is a macular edema which is not resolving, then we can consider vitrectomy in the DR. So we have a paper which is published, which is a relationship between retinopathy and diabetic peripheral neuropathy. And we have found here, you can, with the risk factors of DR, the elevated creatinine was found to be one of the risk factors for diabetic retinopathy. The other risk factors were duration of DM, increased HbA1c, diabetic peripheral neuropathy. And in case of severe NPDR and PDR, duration and peripheral neuropathy was found to be risk factors. So thank you.
Thank you, Dr. Rehna. Any questions from the residents? Yeah, I don't think there are any questions, so I will close the session.
Okay.
Once again, thank you. Thank you, Dr. Rehna. Bye.
Thank
Good night,
you.
all. Yeah.
Good night.